Good morning, everyone. How's it going? How is it going? So, yes, it is cold out here in Eagle, Idaho. I just worked out in my garage gym at home, so I'm still warming up. So, I'm going to be wearing the beanie for this. Let me go ahead and just share this real quick as we're going. Let's see. Can I do that? Can I share this? Hold on one sec. I'm going to let a couple people jump on here live while I'm doing this. And if you're just joining us right now, I'm going to go through a cool lesson that Facebook Live now allows you to share the screen. I haven't been on here a while on a desktop. You can share a screen. So I noticed that this morning and I figured I'm going to go through our level 3 movement assessment for low back pain, anterior pelvic tilt. So if you are interested in learning something clinically bright and early this morning, I'm going to run through it. I promise you I'm not going to disappoint. I'll go very slow with it because I remember when I first started learning this stuff, it took a while. It was remembering all the stuff that I had forgotten from school or all the stuff that you never even learned in school to begin with. Let me just go ahead and share this in a group so that we can see this. Let's see. Group is functional movement for chiropractors. If you haven't joined that group yet, jump inside there. This is live. Okay. Because you're going to want to see all the cool stuff we do inside the functional movement for chiropractors group. Sometimes we put stuff inside there that we don't have inside of our page here for MoveNow University. Okay, so I try to make this a sensational title. You know, if you miss this, you're not going to fix a certain portion of your patients that have low back pain. It's just a fact. It's a functional movement view on this. I feel like it doesn't counteract what we do as chiropractors. It's not in conflict with chiropractic. It's stuff we need to understand with functional anatomy. So where you see this, I'm going to pull this up in just a second, but where you see this problem is if you're doing a movement assessment on your patients, all right, and maybe you're a straight chiropractor that just adjusts, you don't do any functional rehab or rehab at all, have your patient just in your adjusting room do a squat. Okay, instruct them how to do a squat and look for some things in over a deep squat. Now, granted, before I go into this, I just want to tell you this is our level 3 assessment criteria, meaning there's a level 1 and a level 2. Why is that? Because a squat is a very complex movement pattern. It's called a triple flexion movement. You have ankle dorsiflexion, you have flexion at the knee, and then hip flexion. So it's a triple flexion movement, and you're trying to differentially diagnose like what you see in a squat. There's a lot going on. I break it into 5 different functional faults. And the functional fault we're going to talk about here is when you have a increased anterior pelvic tilt, or the person cannot keep their torso upright when they're going into the squat. And there's some different reasons for that. There's some reasons that the functional anatomy, functional movement people are going to talk about. That's what I'm going to represent right now. But I'm also going to tell you about some of the chiropractic end of this, of the benefit of taking x-ray and analyzing x-ray, and also doing some other movement tests, maybe with your patient supine, to see what their normal hip range of motion is. And on x-ray, what you can discover that gives you a better idea of maybe also why the person doesn't have a proper squat. And then this is going to all come back around to helping you figure out, without guessing, without giving a generic protocol to everyone, but give you a definite just plan of action with your patients as far as what tissues need to be worked on, which ones are tight and overactive, which ones are weak and inhibited, and then how to actually get your patient into strength and power, which is going to fix them long term. So I don't lose anyone here with all of this language that I'm going through, because I know it's early in the morning. I'm going to share my screen and I'm going to walk through this. Good morning, Brandy Hunter. Brandy is our office manager at Gonstead Spine and Wellness, our clinic out here in Meridian, Idaho. She's also our MoveNow doctor support. And let me see, where does this let me share the screen? Maybe this doesn't let me share the screen after I start it live. I guess it doesn't. Man, I lied, didn't I? Bummer. Okay, well, let's do this. Let's do this. How are we going to do this? I'm going to post up this picture below in the comments section. Man, Facebook Live tricked me. Just make sure I'm not missing anything. Yeah, you can't show the screen in here. Okay, so here's what I'm going to go through. I'm going to do what's never been done before on a Facebook Live. I'm not going to stop it and restart it. Good morning, Dr. Larry Goodman. Thanks for joining us. What I'm going to do is I'm going to plug in my printer. This is like thinking outside the box now, right? Plug in my printer, and I'm going to print this document that I have up on my other screen here so I can show it to you on Facebook Live. How cool is that? Good idea? Okay. Good idea. Let's see. So we're pulling it over to my desktop. We're blowing it up, and we're going to print. So bear with me here. What I'm going to show you is a flow chart that I made that makes it a lot easier to understand this whole thing that I'm talking about. And I'll point to each part of the flow chart. Make sure my printer doesn't fail me. Let's see. It's doing something. There's a light on my printer over here. So that means it looks like it's going to print. This might just be crazy enough to work. It's printing. Okay, cool. All right. So when this prints out, I'll show you what's going on. And then we have to rely on that Facebook Live isn't flipping this around. I'm going to check real quick on my phone. See, this is some really raw footage right here. No holds barred, not edited. Yeah, you can see it in regular run here. Great. Okay, because I'm not doing it on my phone. So you should be able to see this then. Yeah. Okay, you can see it. Okay, so here's how this works. I'm going to start over. Let me get orientated here. So what this is a document that comes from, there's 4 other documents. Let me figure out how to get this nice and neutral here. Okay, there we go. Then I can still see it. Okay, so over on this side, right here, it says anterior pelvic tilt. That is the functional fault that we're going to see when someone's doing an overhead deep squat. It's 1 of 5. What are the other functional faults in a squat? We're going to talk about that at a different time. I'll keep you in suspense. Right now, we're talking about anterior pelvic tilt. Okay. It says here, it says inability to maintain neutral pelvis and upright torso. So that means when someone does a squat, their pelvis flexes forward really crazy. And from like a physical therapy standpoint or a personal trainer standpoint, even some chiropractic standpoint that maybe don't look at x-ray or don't understand pelvic morphology, they're going to say, oh, that person has tight hip flexors and that's why they're flexing forward like that. Let's just stretch the crap out of their hip flexors, right? Here's the reality. And I don't have a great diagram to show this to you right now, but the reality is this, and this is a principle that is really was discovered in a lot of orthopedic surgery. Okay. And then chiropractic biophysics has recognized this and then looked at this variable and tried to apply it to looking at how do you predict when a patient can have a normal neutral spine, like about a 40-degree lumbar curve and a 40-degree sacral base angle, or what anatomical variables prohibit the person from having a normal neutral, 40-degree sacral base angle and lumbar curve. And so here's what it is. If you look at a lateral x-ray, lateral lumbo-pelvic x-ray, where you can see the femur heads, you can see the sacrum, and I'm going to draw a picture. Again, I'm not going to disappoint with this, guys and gals, okay? Like, we need some diagrams here. So here's what this looks like, and we'll see how great my drawing skills are. I think they're pretty good. Maybe, I don't know. Do I know how to draw a pelvis? We should. It should be a prerequisite to being a chiropractor is that you can draw all the anatomy, right? Okay, so there we go. What does that look like? I don't know. Okay, don't go there, people. Don't go there. All right, get your mind out of the gutter. So anyway, this is the femur. This is the sacrum. Okay, so there is, in most individuals, the sacral base and the femur, they lie almost vertical on top of each other, or the femur is a little bit offset to the anterior this way, okay? So what happens is that the more offset that someone's femur is over on this end, the more forward the femur goes, the more the pelvis has to flex and tilt as a balancing mechanism. That's called increased pelvic morphology, or an increased pelvic incidence angle. So it's an angle that is basically measuring this line. I'm going to draw it in red. Okay, it's basically that relationship of where is the sacrum and where is the femur head. Okay, the more forward it is, and I'll draw this in blue. Let's see, someone had a femur over here. The more forward it is, like this, the more the sacrum's going to tilt, and they're going to have a crazy lumbar curve. Okay, and you're going to see these faults when they do like an overhead deep squat. They're going to have anterior pelvic tilt. They're going to flex like crazy, and you're not going to really be able to change that hardly at all. You know why? Because they have an increased pelvic morphology. So first thing you have to figure out, because that's about 10% of the population, give or take, you got to rule that out. Do they have an increased pelvic morphology? You have to take an x-ray for that. All right. So all of our chiropractors out there that are anti-take an x-ray, hey, look, you really want to fix your patients and understand what's going on anatomically? I'm a huge advocate of taking x-ray, my friends. All right. So you got to take x-ray. You got to measure that angle. You have to understand where's the sacrum in relation to the femur heads. Once you figured out, do they have an increased pelvic morphology, or are they like most of us that don't and have a pelvic morphology that's within normal limits? 56 degrees plus or minus 10 degrees is kind of what's considered normal. Not intending to go into a ton of detail on this right now, because this is already going to be a long Facebook Live. I already know this, but I wanted to at least cover that first. Okay. If they don't have an increased pelvic morphology, then now you go to the next step and you say, all right, is there a hip issue that is prohibiting them from being able to get into a deep squat? What does the hip anatomy look like? What does it feel like? Well, on x-ray, you're going to look for, is there like a impingement issue? Is there a cam deformity? Is there an abnormally shaped femur head? Now, technically, you can do some supine testing, put the patient on a table, and you can take one leg at a time and just bring their leg up into flexion. So you can bring their leg up towards them, and you can hunt around and find how much abduction do you go into, and then you can basically feel the shape of the femur and the acetabulum of where it allows their leg to get into a deep squat position. You can feel where it falls off that little shelf, and then the leg comes up. We cover this in video training inside of our program, inside of MoveNow University. Hopefully I'm giving a good enough visual just using my hands that you can understand. You can put someone face up and basically have them do like a unilateral squat, one leg at a time, test the range of motion, get an idea of where the squat stance should be, to see if maybe when you're having them stand up and do a squat, they're just not wide enough in their stance based on their pelvic anatomy. So what happens is, if they're too narrow and they start to squat down and the head of the femur starts to cram up in the acetabulum, then the only way for them to get deeper is basically, in this case, either they fold forward, okay, trying to compensate, or their pelvis tucks under and they have that butt wink. And you don't want butt wink when they're squatting, especially when they're loading the squat. But again, this is just a functional movement assessment part. It's a non-loaded, non-weight bearing, well, non-loaded. It's obviously weight bearing because they're standing, and you're having them squat. Okay. So that was a long intro, right? Okay. So now the next part I'm going to run through, and I'm going to try to take my time on this. So this could be another 10 minutes of explanation, but I think it's worth it. All right, over here. So I just talked about some of the variables there, and hopefully that makes sense. And then I'm going to try to get my head over here so I can see what I'm doing. So we got anterior pelvic tilt. So let's say the person has an anterior pelvic tilt when they squat and their arms are overhead. That means they have an inability to maintain neutral pelvis at an upright torso, meaning their pelvis has to typically flex forward, right? That's going to cause an increase in their lumbar curve. So that's something that you got to look out for, is do they accentuate their lumbar curve when they do this? And they're going to increase a forward lean in their torso. Now, there's also this thing that you want to look at is, do they have an inability of the knees to track forward because of, in a lot of cases, a problem with ankle dorsiflexion? When you're squatting and your knees start to come forward, all right, you have to have adequate ankle dorsiflexion to allow that to happen. So a lot of these squat issues we're seeing with people is because of an ankle issue. So that goes to the next step of this flow chart of, this is your thought process. Is there a problem in the ankle that's maybe causing this? Is it starting from the bottom up? Let's take a peek. So now the next step of what we're going to do here is we're going to do a test. Is it ankle or is it upper body dysfunction? That's over here. Now, how do you differentially diagnose these two things in a nice little test? Well, if it's an upper body dysfunction, okay, meaning they come down into a squat and the pelvis flexes forward, the interesting thing is that when your arms are overhead, if your lats are super shortened and tight, then that goes all the way down into that lumbodorsal fascia, and it will cause the pelvis to flex when the arms are overhead for them to start to get some depth. So with that one, to rule out the lats, you just drop the arms, have them do a squat again. If the squat cleans up and their pelvis looks good, it was an upper body dysfunction that is causing this compensation that you see in the lower body. So then you have to figure out with that, you don't just leave it at that and say, oh, it's the lats for sure, because it can also be the lats and it can be teres major and subscapularis. All of those three muscles are the muscles that are responsible for causing a problem with adequate shoulder flexion, also pec and other stuff, but long head of the bicep. But for the sake of this little differential diagnosis exercise that we're going through, what you're going to do here is you're basically going to have them put their hands on their hips. They're going to drop their arms. Did the squat improve? If it does improve, then you know it's an upper body dysfunction. You can do what's called a lat length test, which we have videos showing how to do this. You can look it up on your own and watch someone else make a video of it, lat length test. And then you're going to differentially diagnose, is it teres major and subscapularis and lats, or is it just lats? Okay. That's what you're looking for right there. So on to the other one here, the other direction of ankle. So now if you drop their arms and it doesn't change at all, now you're going to test the ankle to see if the ankle allows it to change. How are you going to do that? You're going to put a lift under their heels. Have them step on a 2x4. All right. Keep the arms overhead, do a squat. If the squat improves, then you do protocols to increase ankle dorsiflexion and you retest. The arrow goes over here. You see what's weak and inhibited, which is their dorsiflexors, tibialis anterior. You test the tibialis anterior. Is it weak? You just do a quick little muscle test. Is it weak? And most people it is. You teach them how to strengthen up their tibialis anterior. You do stuff to increase ankle dorsiflexion and, look at tight, short, overactive gastroc and soleus. And you do stuff to tone it down and lengthen those tissues. Okay. So that's the first part of this. We've covered all of this now. Now on to the fun part. Okay. So now this is where I remember initially when I was putting all the information together and trying to wrap my mind around it, make it like an easy flow chart. Because even though there's a lot of stuff on here, this helps take the thought process and demystifies all the variables where people just be like, well, there's a lot of reasons that people have a problem with their pelvic tilt, so I'm just not going to learn any of them or test any of them, or I'm going to do an overly simplified approach, which is only going to help like 50% of these people. So instead, you have to differentially diagnose this if you want to be a good clinician with this. And if you want to fix your patient's low back pain and problems and dysfunction in their low back, you should be looking at something like, what do they do when they squat? All right. And if your patient can't squat deep because they have a knee problem or something else, clear that, try to help with that. Then you retest, and then this stuff comes out. And now you have lots and lots of cool stuff that you can help your patients with. Okay. So this next part right here talks about, okay, let's say you've ruled out all this stuff. You keep going. It can also be looking at what tissues are tight, short, and overactive. And in this case, hip flexors. So hip flexors, spine extensors, or both, that can cause the pelvis to flex when you're going into a deep squat. So now I color coded this, and I have erector spinae and lats. Those are both spine extensors. That's what that little bracket over here means. So rector spinae and lats are both spine extensors. Okay. So the lat little arrow goes over to the lat length test, because when you're doing that, you can see upper body dysfunction, and you could start to think, okay, there is some stuff with the upper body that's also affecting this. You still go through this whole thought process. You still test all of these tissues over on this side. Then you have hip flexors. You have psoas and iliacus, which we pretty much pair together because it's hard to differentiate those two in testing. You have TFL, so tensor fascia lata, and you have rectus femoris or rectus femoris, if you want to say it that way, tomato, tomato, right? Then I put the orthopedic tests right next to it. These are actually good orthopedic tests. I know in school, when we learn orthopedic tests, in my mindset, when I was like strict adjustment only chiropractor, I'm like, why do I have to learn orthopedic tests? And you kind of did them to go through the motions in your patient assessment. So you had them on paper. And then years ago, I started realizing, wow, you can actually use this stuff to differentially diagnose, and it works. And then you can start to dig deeper on your patients and fix this stuff. So these are good orthopedic tests that you should get good at doing and understand what they mean. And these are the tissues that will cause a increase in pelvic flexion. So psoas iliacus, TFL, rectus femoris, and the anterior adductors. You don't really have an orthopedic test for the anterior adductors, but you can palpate. Okay, you can palpate, you can compare to all these other tissues. You could rule out these three things and they still have the problem, and it leaves the one tissue left over, and it screams anterior adductors are in trouble. But for the most part, it's a combination of a lot of these tissues. There's patients that we take through these tests every single day. And I'll tell you, some people, usually what we usually see that they have a problem with all of these tissues, or we see that it's really more of psoas and iliacus. Okay. And some people just have a tight TFL, and that's what's inhibiting them, and everything else tests fine. So those are the different things that we usually see clinically. But I would say the most common thing that we see is psoas and iliacus are very tight and overactive in these people. Okay. So now let's say you identify these tissues. You have some protocols that you do to tone down the stuff. We have all the protocol videos inside of our program, and they're all simple. It's all simple stuff. We have this thing called a home mobility kit that our MoveNow doctors use in clinic. They send their patients home with the kit. So they sell this kit to the patient, so the patient can have tools that they can use pretty much indefinitely once you teach them these protocols, so that they could use this if that's their biggest trouble spot in their body. But they're not going to be doing all these little corrective exercises over and over and over again forever. What they're really going to be doing is they're going to use these protocols that we teach them to get them out of the crisis. They're then going to get into functional movement loaded exercises, usually with a kettlebell or resistance band or even a barbell. Okay. And that's going to reinforce these healthy patterns. However, these people need to have a warm-up process. The warm-up process is going to use those tools to get the tissues warmed up, get other tissues activated, and then they're going to go into these exercises to help reinforce the healthy patterns. That's a big part of what we talk to our patients about from day one, is that we're going to get you exercising. We're going to get you building some muscle and building strength. And people love that. People love that idea, that concept. A lot of times they didn't do it because they hurt. They're afraid they're going to hurt themselves. They don't know where to begin. They just physically can't go through that movement. And once you fix that for them, it opens up their eyes. And a lot of these people want to exercise. Okay. So anyway, I'll keep going here. Last part of this is the thought process. Anytime you're working on fixing a movement pattern is, again, you look at what is the problem? What are the compensations? What are the tight, short, or overactive tissues involved? And what are the overactive synergists? So now overactive synergists, I'm going to explain that real quick. The best analogy I've heard, and man, I think this was, I don't know if it was Brett Brookbush that said this or Gray Cook. They're both big time physical therapy guys that teach a lot of functional anatomy stuff. Great resources. They talk about this analogy of like in a top level company. Let's say there's this top level SEO or CEO, sorry, not SEO, search engine optimization, CEO, so top level CEO in a company, and he does some really high power jobs and he's out sick. Okay, so he's out sick, and now you got 3 interns who know pretty much how the job works, and 3 of them together can piece it together, can get the job done, can keep the company afloat until the boss man comes back. They can do the job, but they're exhausted, man. It is hard for them to do it because they don't have the experience. They're not really the person that's supposed to be doing the job, so they're filling in. So they get exhausted, they get burned out, and they can't maintain it forever. And then things start to fall apart in the company if the top level CEO doesn't come back to work. That analogy is how an overactive synergist works versus a prime mover. So for example, your glute max and glute medius muscles are the prime movers for hip extension, for driving your leg backwards. Okay, that's what's supposed to happen. However, the overactive synergist is biceps femoris. I have that right here. I'll just show you. Okay, biceps femoris, long head, technically. Adductor magnus, posterior head. So those are things that cause the leg to extend. Piriformis and erector spinae. You see piriformis on there? Hopefully some light bulbs are going off in your mind right now if you're kind of new to a lot of the functional anatomy stuff. What is usually tight and overactive and painful in a huge portion of our patient population? Piriformis, ton. Hamstrings, ton. But a lot of times those muscles aren't muscles that just need to be stretched forever and ever and ever. They need to be toned down. The reason that they are so tight and overactive is not because they are inherently shortened, but it's because they are working too much because the prime movers are not working. So you've all heard this, like glute needs to be activated, glute amnesia, the butt fell asleep at the wheel, you know? So the problem with that though is that if you're not doing stuff with your patients to activate the bigger muscles and being able to tone down the overactive synergists, when you go through these different exercises to try to activate, they're going to use the overactive synergist to get from point A to point B. They're going to use that to bring their leg into extension because they don't know the mind muscle connection on how to turn back on that prime mover. So there's little tricks and things that you do and you have your exercise staff do to accomplish that. You explain it to a patient, it's like an epiphany for them. Okay. They love the fact that you can educate them as you go as to why you're doing this because it's so unique and different from anything they've ever heard before. No one's ever explained the science behind it. That's what we do in our clinic. That's what we teach to our doctors, is how to really talk the talk because you're delivering high level care. So what has to happen, these are the interns. Okay. You have to relieve the interns so big boss man can come back, because if you don't, these guys are going to get from point A to point B. They're going to make that joint action happen, but it's not going to last long. You're going to get exhausted. These tissues are going to start to become painful. A lot of this low back and pelvic pain people have from like overactive tight piriformis and hamstring and adductor magnus and low back erector spinae. It's because every time they take a step, the way they're driving their leg into extension is not from glute activation, but it's from all the overactive synergists driving the leg behind them to accomplish that joint action, to get them to move forward. You see this in a lot of runners that are not activating their glutes. Look at a runner that has an increased pelvic tilt or has this kind of failure in overhead deep squat. And I'll show you a runner that's got super overly developed erector spinae, super tight, like guitar string piriformis and hamstring, and their glute is really not doing the job. Okay. So now this last part, what you have to do here with looking at hip extensors. So overactive synergists, you want to tone down and lengthen the overactive synergists. Okay. Initially, this is like the order of how you're doing this exercise with your patient for that session. So for that session, they're going to come back, you're going to tone this stuff down. So okay, it can breathe, it can relieve. Then what you're going to do is you're going to come in and you're going to start to activate the prime mover. Okay, so glute max. Go down to glute medius, also very important. TFL, all right, TFL tries to take over and a lot of times is tight and overactive over here. TFL tries to take over when the glute medius is not doing its job. So glute medius is supposed to do what? Abduction. Okay, so It does some abduction and extension. TFL doesn't do any, well, sorry, TFL is a flexor, right? So when you are having the patient activate glute medius, it says here, reciprocally inhibit the TFL by extension of the leg when testing or activating. If you bring the leg into extension and you don't allow it to be neutral, because the person's going to cheat and try to flex and pull in TFL, hip flexor. If you extend the leg and then teach them how to do some glute medius activation, it's going to force them to really activate glute medius, because nothing else is going to help out, because you reciprocally inhibited the tissue. Last thing I'll cover here, and hopefully this is intriguing and you'll go back and watch this maybe a couple times, and I'll post this chart below in the comment section, is there's a firing order as well that we also test. This is part of our MoveWell 3 movement assessment. We actually test the firing order when someone's dysfunctional on a squat. And the firing order, glute max should be first, bicep femoris second, erector spinae third. When someone is face down and you have them lift their leg into extension, you put your fingers like this. You put your pinky finger here on erector spinae. You put thumb and thumb on glute, okay? And then you put your other pinky finger, I don't know what pinky I started with, this one on erector spinae, glute. This is hard to do, like mirrored on a computer, I'm telling you. So I have pinky on one hand on erector spinae, and then these thumbs on glute, and then other pinky is going to be on the hamstring, and you're going to instruct them to move their leg into extension, and you're trying to feel which muscle is firing first. And what's supposed to happen is glute max should fire first, hamstring bicep femoris should fire second, erector spinae third. What happens with most people? Erector spinae first, hamstring second, glute barely doing anything in third. That's normally what you see. So knowing that, living that, teaching your patient that, very important. I'm going to post this below. Hopefully this is helpful. This is a very detailed, broken down process, but I try to make it simple. I know I took a good 30 minutes to explain it, but I think it deserves that attention. Okay. So with that said, comment, let me know what you think below. Ask me questions if you have questions. If you want to see this whole thing in action, watch our demo. If you're not a member of our program, watch our demo, demo.movenowu.com. And I take you through all the programming inside, and I show you how the clinical side is one side of it. All the procedures and the testing forms and the patient communication and the patient resources and the staff training, all of that is inside the program as well. This is just one piece of it, which is the clinical part. So hope you enjoyed. Hope you have a great day. We'll talk real soon.